good morning, everyone, and thanks for having me here. Talking about newer treatment options in pancreatic cancer, and I thought that, I don't want to just give a list of all the kind of new medicines that are going on, because frankly, the list is never ending. And that list just tells me that there is nothing good available for pancreatic cancer. And that's the reality. We try and we attempt a lot of medicines, but end of the day, as of now, the kind of breakthroughs we have seen for, say, a lung or even a breast cancer have not really come for this rather complicated cancer. When I talk about neoadjuvant and adjuvant therapy, it's basically a Mexican standoff. You're having radiation, targeted therapies, Gem-Nab-Paclitaxel, FOLFIRINOX, good old drugs, and immunotherapy. Various combinations, multiple sequencing. You give radiation first, you don't give radiation at all. You will find a trial to back up whatever you want to do. So it's really a high time that a center with a high load will have to frame up its own sequencing. So for example, in my center, for a borderline resectable, we would give neoadjuvant chemotherapy only 2 to 3 months. We had toyed with the whole idea of adding radiation, but did not find much benefit. So we are not doing that right now. We are giving only 2 to 4 cycles of chemotherapy, going with a surgery, completing your adjuvant therapy. For a locally advanced, we are treating only with chemotherapy. As of now, we have not published the data. We have around 10 patients where we tried to give so-called consolidation radiotherapy after chemotherapy in non-progressors. Patients progress within 3 to 5 months. So it's something that my radiation colleagues have become very less enthusiastic about. We are not really doing it. Yes, there is data coming up for SBRT. We have tried it in a few patients. The results have not been spectacular. So again, the way to go for a neoadjuvant and adjuvant is to have an institutional specific protocol, follow up 10 successive patients with it, and then come to a result. There is nothing really outstandingly new that has happened in this phase, in this scheme of neoadjuvant and adjuvant. Coming to metastatic, this is what I feel like a headless chicken running around trying to figure out what to do. And again, results are not great. Now, if you want to be the optimist, you can look at this table and say that the approved therapies in the last 6 years, there have been almost nine new approved therapies in the US FDA. The first started with 5-FU nal-irinotecan, which again we do not have. Then you have a Gem-Cap that was for adjuvant. Then, of course, you have the pembrolizumab, you have larotrectinib, entrectinib, again pembrolizumab, and dostarlimab. Now, all these, if you realize, are tissue agnostic. So you have TMB high, you can give it. You have MSI high, you can give it. Dostarlimab, to my surprise, has been approved by FDA as a MSI high agnostic approval. So again, you have one of these MSI high, go ahead, use immunotherapy. Percentage-wise, 1 to 2%. You have BRAF V600E. This is again a tumor agnostic approval which came this year. Give dabrafenib, percentage-wise, 1 to 2%. Then you have the NTRAX. I have seen one NTRAC in the last whatever I have been testing. It is not common. Now, all this together would possibly give you 3 to 5%. In the context of a disease like pancreatic, I would still encourage patients to do the testing. Do I do TMB for everybody? I think that's a whole debate for its own day. I am not really pushing for a TMB for all patients. I usually do MSI. I do send a CGP and try to find results, but it's not very satisfying. So what else came around that was interesting, got some interest, but then fizzled out? The most, that data was the olaparib data. Now, this was in 2019. When we found that for BRCA mutated metastatic pancreatic cancer, germline BRCA1, BRCA2, okay? There's a lot of confusion going on. What is BRCA1, BRCA2 in terms of olaparib? For pancreas, the data is with the germline. For germline BRCA1, BRCA2 mutation, this was the study which came in 2019, showed you a PFS advantage, which was good. And you could see the curves slowly separating out. Unfortunately, this year results have come out, which were overall survival results, and that was negative. So in this study, they randomized not a huge number of patients, 92 to 62, but no different benefit of OS. Median overall survivals, again, were not great. It was 19 versus 19.2 months. So hazard ratio of 0.83, crossing the unity line. 3-year survival, if you want to look at something like that, is 33 versus 17.8. You have a whole bunch of secondary endpoints: medium time to first subsequent therapy, time to second subsequent therapy, time to discontinuation, all of which were better for olaparib. But again, the PFS2 is non-significant. So for me, a PFS2 not being significant and OS not being significant, data is losing its luster. And the conclusion of the authors was that you don't have statistically significant OS, HR numerically favored olaparib. Would I use this drug? Again, if I find a BRCA, well, maybe I'll think about it. Would I go hunting for a BRCA in a pancreatic cancer in every patient? Possibly not at this point. So that's my take on this data. Now, aside from this, what all do we have? Can we do a CGP and find out mutation analysis? I've not put that slide, but by and large, the most important mutation seen in pancreatic cancer is the RAS mutant. You have KRAS, you have NRAS, you have different mutations. Almost 60% are actually RAS mutations. We know that RAS is not as easy to target. We are coming into an era of RAS inhibitors. We have 2 available in the market. We should be coming up with this data in some time. I think in the next 2-3 years, this is something we are going to see. One of the few positive trials that actually came out this year in the ASCO was actually about nemotuzumab. Now, this really caught my eye because nemotuzumab is something we have. It's the good old biomab. We are used to it, and we know what this drug does. Now, this was a phase 3 randomized trial, multicentric, double-blinded trial done in patients with KRAS wild type only. So locally advanced or metastatic KRAS wild type. Used gemcitabine versus gemcitabine nemotuzumab. So again, first point, it's only gemcitabine. We are not using the backbone of gem-nab-paclitaxel. We have not used the backbone of FOLFIRINOX. So that's to be taken with a pinch of salt. So nemo-gem versus gemcitabine. The study was called the Notable study. Now, interesting is the dose used here. You can see here the nemotuzumab is 400 mg weekly. Typically, we give 200 mg. This is 400 mg weekly. So continue weekly for whatever months you have to. It's not easy. Cost-wise, of course, leave it alone. But even the reason why they use 400 versus a 200 in other areas was not mentioned, and I could not find that reason. This, along with gemcitabine, which is a standard dose, weekly dosing, and then on follow-up, the primary endpoint was overall survival. The PFS very mildly increased, 4.2 to 3.8, hardly that significant, though it is statistically significant, 44% reduction in number, which is not much. If you look at the baseline, overall survival, it did show a benefit of around a couple of months. That's something which is interesting. But again, look at the overall survival. It's 10.8 versus 8.5, something like that. And the previous study, the BRCA study I showed you, was 19 months median OS. Now, was that because it was including locally advanced? Maybe patients got multiple lines later. We don't know the reason for that. But this is something more what we see in a metastatic pancreas. So Nemo plus GEM regimen did improve MOS here. Would I do this in India? Again, it is a thought which I will have, but with the dose, certainly not at 400 mg. 200 mg is a possible good dose. Would I give it weekly for 3 to 4 months? Again, debatable. But if patient is coming for GEM, I guess we can add it with that. Possibly I would modify it, give weekly, and then the 3rd, 4th week when we don't give anything, I might omit this drug. We are learning a lot about the pharmacokinetics of all these MOABs, and we know that it is not as easy as a chemotherapy drug. So possibly you give like that, it might work. Again, this is my thought. Please don't go and quote me on doing this. There's no study for that. Interestingly, the overall response rate here was not different. Look at the total response, including the stable, and the response was almost same in both the arms. That's something, again, well, something we would have liked to see, that there was a better response, which was not there. Subset analysis, why they said it reduces everywhere, but that's possibly what we see. Now, the other study which I thought looked interesting was this sotigalimab and or nivolumab. Sotigalimab is an anti-CD40. I'm not interested in that drug. It'll never come to India, so I'm not bothered about it. I found it more interesting because of the nivolumab part. So nivolumab plus chemo has been used here. And what they found is that nivolumab plus chemo versus this combination versus only the nivolumab showed some benefit. So this is one of the few data which actually showed benefit of nivolumab. So do we have again a phase 3 data of adding nivolumab? No. Would I still tend to add nivolumab? Well, previously I was not saying there's no evidence. This is some small evidence from a small trial. Another trial including nivolumab with or without ipilimumab combined with SABR. Now, this is one more thought process. Gives SBRT to the primary, induce neoantigens, and let your immuno work. That's the theory. This trial not really did not work. In fact, the response rate, the clinical benefit rate was lower significantly for the combination of SBRT with Nivo versus SBRT with Nivo, EP, and nivolumab. Now, there should be another arm saying only SBRT or only chemo, which is not there. So that's the flaw of the design. That's how it's been designed. So again, would I jump to do it? It would be great if you could have a consortium and decide at least 10 centers, give SBRT for 5 patients each and then see what happens. But I think we are a bit away for all that. We need to hopefully strengthen it in the few times, because the problem with India as it is, all of us have ideas, but none of us are able to put it into practice and get people involved. Now, this is the KRAS that I was talking about. So there is a first data for sotorasib in patients with pancreatic with G12C, phase 1-2 study. Again, results are, well, I'll say okay. They're not fantastic. You have a 21% overall response rate. Median duration of treatment is around 2.8 months. And the median PFS is 4 months. So again, not hugely impressive data. Again, we know sotorasib is not what it seems to be. We got very excited in lung. The colon data has come out, which is kind of dampening. This data is again not so great. Beyond this, can we do CGP? Can we evaluate? Can we do vaccines? There's so many things happening, and it's really a multiple targets. When I tried to Google it, I found so many papers with so many approaches. It's really not worth highlighting each one of them because we are not going to do any of it. What all do these include? Again, the lay press has sensationalized CAR T-cell therapy, one-odd case reports here and there. And this is an area where personally I feel we are going to be doing something. In the future, CAR Ts will come for solid tumors as well. The challenge is what antibody to use. So one of the studies used a thing called, one of the studies used an antigen called EAP-CAM, something like that, which is specific for pancreatic cancer. So if you find more such antigens, possibly CAR T is something we can look at. There's a DDR pathway inhibitor, again, LP184. It's going to start human clinical trials, and FDA has given it breakthrough orphan drug designation. So, that's how possibly the field is so barren that people get orphan drug designations before any studies. You have something called a MUC5AC antibody. Then you have something interesting like the tumor treating fields. I used to think this is science fiction, but there's a phase 3 trial being done for this. So treatment fields, electrical current being stimulated in the body along with chemotherapy. So let's see where we get. So for me, the take-home messages are really right now that it is a time of hope. We are going to get new drugs sooner or later. But at least in the neoadjuvant, we are trying a lot of combinations and sequencing with immuno, with RT and so on. Let's see if any one particular thing wins the race. Metastatic, only tissue agnostic drugs as of now, which we should look for. Immunotherapy, interesting results. Let's wait for conclusion. For me, the future remains targeted therapies and possibly CAR T. Maybe I'm sticking my neck out too much here, but I think 4-5 years down the line, unpronounceable CAR T names will be what we'll be discussing in our meetings. So thank you.
Thank you so much for this pancreatic. But in the metastatic pancreatic cancer, there are the agonistic tissue factors are only available.
Yeah, as of now, yes. We, again, don't find this particular mutation. Again, the expert is there. We can always discuss. There'll be some mutations. You might try combinatorial approaches and all. Will all of them really yield a very superior rate? We don't know. There's no hard evidence of any particular such combination in pancreas, at least.
And TMB and all that things
it's all tissue agnostics. So again, like I said, TMB we can argue till the cows come home. I am not doing it personally because unless you're doing a big CGP, you won't get the TMB. And chasing TMB specifically, asking patients to do it, I don't find the value in it. I prefer doing just the MSI, more for logistical reason, no other reason. You're not wrong if you push for doing a TMB in every patient.
Any other questions? Yes.
So at our center, we are going with FOLFIRINOX whenever the patient is able to tolerate it. And where the tolerance is slightly iffy, we are giving Gem/Nab-Paclitaxel.
Yeah.
Did you make any
Yes. We are getting around 20%. So again, we have to be careful of what we are looking at. If it is a borderline or resectable, where there's an abutment of a vessel less than 180 degree, but you want to give some chemo, it works well there. Where it is more than 180, there is complete encasement. There's no point. Once it is the SMV is encased, when the SMA is gone, the celiac is gone, there's no point. There we are just giving chemo. We are not even attempting a surgery there.
Yeah, so a very good presentation and difficult to treat cancer actually. So do you think that going for that, again, you highlighted you are not doing TMB. So do you think there is a rationale to do TMB? They are cold tumors actually. So something has to be looked to make them really hot. I don't know whether SBRT, I mean, it has not proven to do that, or any other drug targeted something to make it, make immunotherapy work for it.
It's a good idea.
Time, I think will not get any answer out of it.
I
It's
agree.
absolutely the cold tumor. So TMB, I don't believe TMB in pancreatic actually.
So again, my logic is very simple. If I find a one-off patient out of 100 with TMB high, I am fine to use immuno there. Will I find it in 10 out of 100? I don't think so.
And the cutoff matters actually, where there is a cold tumor. So you don't have a clear-cut criteria over.
So again, I would personally possibly jump to at least 15 and above. Less than 10, I don't know. Dr. Amit, 10 to 15, would you consider it good enough for giving, or would you want 15 to 20?
In pancreatic.
Pancreatic. More than 20. That's what. It's a dynamic thing.
Thank you so much.
Thank you.
Second one is the hepatocellular carcinoma. So novel